Today the topic is of pediatric ECG case-based discussion. First, I will brief the basics of pediatric ECG. Then, in the meantime, subsequently, I will take the cases in between. As we all know, the physical examination, ECG, and X-ray makes every patient falls into clinical diagnosis for congenital heart disease. ECG helpful in follow-up in case of hypertrophy and hypervolemic state. ECG helps in identifying the cardiac malpositions, various forms of congenital heart disease, as I will discuss subsequently, ventricular atrial hypertrophy, pericardial and myocardial diseases, electrolyte imbalance like hypokalemia and calcemia, atrioventricular, intraventricular conduction abnormalities, etc. But there are few challenges in pediatric ECG as there is different range for different age group. Pattern that is normal for one age group may be abnormal for other age group. I will let you know. In pediatric age group, right ventricle dominance is there and axis is directed rightward, usually 120 degrees there. It is normal in pediatric age group. Between 1 month to 3 years, the ECG can be intermediate. And the congenital heart disease and post-repair congenital heart disease ECG may have different patterns. As we all know, there are limb leads and chest leads are there. Limb leads can be in the form of bipolar limb leads named as 1, 2, 3, and other threes are augmented unipolar leads known as named as AVR, AVL, and AVF, and chest leads are named as V1 to V6. As we can see in this picture, V1 is on the extreme right, V2, V3, V4, V5, V6. And in case of dextrocardia, we have to take the right-sided V3 and right-sided V4. Lead 1, 2, 3. Lead 1 is between right arm and left arm. Lead 2 is between right arm and left leg. Lead 3 is between left arm and left leg. These three will form a equilateral triangle known as the Enthoven triangle. If the wave of depolarization spreads towards the recording electrode, this will give a positive deflection and vice versa. How do we place the leads? V1 is on the right fourth intercostal space at the right external margin, and V2 is just opposite on the left side. And V4 is in the fifth intercostal space at the left mid-clavicular line, and V3 is between V2 and V4. V5 is in the same line, but it is at the anterior axillary line, and V6 is in the left mid axillary line. So we have to keep the chest leads like this. How do we read ECG paper? ECG is a paper is having horizontal deflection, horizontal line and vertical line. Horizontal, one small segment is equal to 0.04 seconds. It measures the time, and vertical one segment is like this. Vertical one small segment is equal to 1 millimeter. So one small horizontal segment is 0.04 second, and total 5 will constitute 0.2 seconds. Now steps in ECG interpretation: the P wave amplitudes, duration and axis, PR interval, QRS duration, axis, amplitude, and Q wave amplitude also, ST segment and T wave abnormalities, QT interval, heart rate, and rhythm of the ECG, whether it is arrhythmic or not. This is a cartoon showing the normal ECG. First deflection is the P wave corresponding with the atrial depolarization, followed by QRS duration leads to the ventricular depolarization, followed by the P wave. It represents the ventricular repolarization. From the start of P to start of QRS is PR interval. Another entity is PR segment. PR segment is different because it starts with the end of P wave to start of QRS. Similarly, QRS duration from the start of Q wave to end of S wave. This is QRS duration. QT interval is from the start of Q wave to end of Q wave. So because we generally measure the PR interval and QT interval in every ECG, so these intervals are important. And between 1 hour to another hour is the RR interval. This generally corresponds with the heart rate. How do we calculate the heart rate? The simple formula is just count the big boxes. This is a big box. 1, 2, 3, 4, almost 4.5 is the big boxes are there between two RR interval. Divide 300 by these 4.5 boxes. It will constitute around 70 to 80 heart rate is there. So just divide the 300 by the large number of large boxes. This is a simple method. As we all know, the heart rate varies with the age. Newborn is having the highest heart rate, followed and it gradually decreases with the as the age progresses. Residents are there, sir. Residents, please comment whether this ECG is sinus or not. Let it be some interactive. You can mention in the chat. Chandrika, Dr. Chandrika.
Yes, sir.
This is sinus or not sinus?
Sir, it is sinus rhythm.
What is the meaning of sinus?
Sir, that the rhythm is followed. The PQRST, the normal rhythm is followed.
Every QRS should be preceded by P wave. So in this ECG, as we can see, every QRS is preceded by P wave. This is a typical sinus ECG. As we can see in this ECG, this every QRS is preceded by P wave. This is normal sinus rhythm. The regularity is regular, and P wave should be applied in lead 2, and one P wave is in front of every QRS complex. Their interval is generally constant between 1.12 to 2.2 seconds, and QRS is always less than 0.1 second. 1 minute. What about this, Chandrika? Is this sinus or not sinus?
Sir, it is not preceded by a P wave, so it is not sinus rhythm.
This is sinus. This is sinus tachycardia because you can see this deflection. P wave is superimposed on the P wave. This is sinus tachycardia. This is a case of sinus tachycardia. Every QRS is preceded by P wave. Sinus tachycardia will have the high heart rate, so the P wave will superimpose on the T wave. So the rhythm is regular, and the normal heart rate in children is less than 180, and in infant it should be less than 200 to 220 beats per minute. Treatment of sinus tachycardia, as we all know, the treatment, we have to treat the cause and we have to do the lifestyle changes. Another is, और कौन है residents में? चंद्रिका है, Saradeep. Arun.
Sir, every P wave is preceded by QRS.
Is this regular or irregular?
Sir, irregular.
But every QRS is preceded by P wave.
Yes, sir.
This is sinus, but
yes,
regular heart rhythm is there. This is a typical example seen in pediatric age group known as the sinus arrhythmia. Regularity is irregular, and हमारी ओपीडी में जनरली क्या होता है, मोस्ट ऑफ द टाइम पेशेंट्स आते हैं, उनकी कंप्लेंट ये होती है, उनके पीडियाट्रिशियन ये बोलते हैं इसकी हार्ट बीट बड़ी इरेगुलर चल रही है, इसको पीडियाट्रिक कार्डियोलॉजी को दिखाओ. तो हम ईसीजी कराते हैं, तो मोस्ट ऑफ द टाइम दिस टाइप ऑफ पैटर्न विल कम, एंड दिस इज नॉर्मल फॉर पीडियाट्रिक एज ग्रुप, and the rhythm will slows on expiration and speeds up on inspiration, and it always indicates this is a normal thing. Now coming on the P wave, are these P wave, whether P wave looks like is actually a P wave or something else? Do the P wave looks all alike or some different type of P waves are there? Do the P wave occurs at a regular rate or irregular? Is the one P wave before every QRS? Interpretation is normal P wave, as we know that every P wave should precede QRS with normal P wave axis. And for interpreting the P wave, the best lead is lead 2. And sometimes we have to use the lead V1 also. Normally the P wave duration is less than 3 mm. And the duration of normal P wave in infant is less than 0.07 second. And in children is less than 0.09 second. The amplitude you have to keep in mind is always less than 3 mm. This is a cartoon showing the normal right atrial enlargement, left atrial enlargement, and biatrial enlargement. And in case of right atrial enlargement, the peak P wave, P pulmonale, known as the P pulmonale, the amplitude will be more than 3 mm. more than up to 3 mm is normal, more than 3 mm in inferior leads. Inferior leads is 2, 3 and ABF. And more first part of the P wave in V1 represents the right atrium, second part represents the left atrium. The first part 5 mm. Similarly, for the left atrial enlargement, it is known as the M-shaped pattern. First part is by the right atrium, second part is by the left atrium. In case of left atrium, the second part will be enlarged. And broad bifid P wave will be there, and the V1 will have the inverted part, will have the broad segment. In case of biatrial enlargement, typical M-shaped pattern and the broad and bifid pattern will be seen in case of V1. Now coming one example, this is a 5 days old neonate, deeply sinused, duct-dependent pulmonary circulation. Patient is dependent on the PDA for survival. Any comment on the X-ray? What it can be in a cyanotic heart disease? Newborn.
So top.
Top will not have cardiomegaly.
Sir, TGA?
है? क्या? PDA will not have cyanosis. Patient is already dependent on PDA. Duct dependent means already dependent on the PDA. But it is the patient is deeply sinosed. Cardiomegaly is there or not?
Yes, sir.
Yes, sir.
The right heart border is hugely enlarged. Right atrial enlargement is there. This is a typical X-ray of Epstein anomaly. The Epstein anomaly will have the pulmonal. Himalayan-like P wave will be there in lead 2. You can see here, this is the P wave. P wave is just looks like the QRS amplitude. So this is Himalayan P wave. This is typical ECG of Epstein anomaly. You can see here also the first peak part is there of in AVR, because AVR is having the negative P wave. Okay, this is a Epstein anomaly ECG. Similarly, in a Epstein anomaly, the QRS will be splintered. You can see the QRS is bifurcated into 2 parts. This is splintered QRS is a typical seen in Epstein anomaly ECG. That I already told. PR interval, beginning of P wave to beginning of QRS is known as the PR interval. Duration, as the age will progress, the interval duration will increase. In less than 3 years, it is 0.08 second, and more than 16 years is up to 0.12 is normal. A case, adolescent patient came with a history of palpitation and giddiness. Examination, clinical examination, blood, X-ray, everything is normal. Echo showed LV dysfunction. Any comment on anyone? Any comment on the ECG? Adolescent patient with palpitation history. Other things are normal. See V1, V2, especially. Arun?
Narrow QRS complex, sir.
Yes, agree.
Sir.
Narrow means it is normal for the age.
Yes.
What is the relation between PQRS? The upstroke of QRS is slurred.
It's slurred, sir.
This is typical ECG of WPW syndrome with short QT, short PR interval with slurring of QRS upstroke. It is always seen in WPW syndrome. The treatment is beta blocker and permanent treatment is radio frequency ablation in the cath lab. Another case related with the PR interval is 10-year-old female, known case of rheumatic heart disease, currently asymptomatic on secondary prophylaxis. Everything is all right, but the ECG is this. Chandrika? और कौन है? अनिशिता है और अनिशिता और सरदी.
Prolonged PR interval.
Prolonged PR interval. कौन बोले सरदी?
Yes.
Okay. Prolonged. This is first degree heart block seen in case of rheumatic heart disease. Okay. And in the minor criteria, first degree heart block is in the minor criteria for the Jones. Okay. Prolongation of interval is seen in case of Epstein, AV canal, in congenital heart diseases की बात हो रही है. Obscene AV canal and atrial septal defect, digitalis toxicity, not in digitalis defect, and hyperkalemia. Short PR interval, main example in pediatric age group is the WPW, pre-excitation, and variable PR interval is seen in Mobis type 1 AB block, Banky-Beck phenomena. PR interval, as the age will progress, the PR interval time will increase. In 0 to 1 month, it is 0.1 second, and in adults, it is around 0.12 to 0.15 seconds. QRS duration varies with the age. It is short in infants and increases with the age. In infants, if it is more than 0.08 second, it is abnormal. In adults, if it is more than 0.1 second, it is abnormal. Wide QRS duration is generally seen in pre-excitation, bundle branch blockage, ventricular arrhythmias, and ventricular pacemaker. Generally, in pediatric age group, it is difficult to see unless there is a bundle branch block. QRS duration, as the age will progress, the QRS duration will increase. In adults, it is up to 0.08 to 0.1 second is normal. How do we assess the axis? Normal axis is between -30 to +90. Left axis is -30 to -90. Right axis is +90 to +180. Northwest or extreme axis is -90 to 180, +180. For axis interpretation, quadrant method I generally use. There are other methods also, but I feel this is the easiest method to assess the axis. For this, we have to take the lead 1 and AVF. The positive, मैं बताता हूँ, ये कार्टून है जिसमें ये है कि लीड 1 इधर है. पहले लीड दिखाता हूँ आपको. Lead 1 direction is here. Lead AVL is here. AVR is here. Lead 2 is here. Lead 3 is here. Lead AVF is here. Lead AVF is inferior. Second, 3 and AVF are the inferior leads. Lead 1 is on the right. Positive is on the right. Lead AVF positive is on the down. Minus is on opposite side. So coming on the previous cartoon, lead 1 is having positive QRS, lead AVF is having positive QRS. So lead 1 positive is here. We have to draw here, and lead AVF is positive here. So normal axis will be somewhere in between of this here. So this quadrant is of normal axis. Similarly, lead 1 is positive. We have to draw a line here, and lead AVF is negative. Negative AVF will be up. So axis in between of these, the axis will be somewhere here. It is left axis. Lead 1 is negative. Lead 1 is negative means we have to draw here, because here is the positive, here is the negative, and lead AVF is positive. Positive is here, so we have to draw here. So somewhere in between of this, the axis will be here. It is a right axis. And if both are negative, negative is here, negative is here, the axis will be somewhere here. This is extreme axis or northwest axis. Coming to the cartoon, normal axis is, as I told you, -30 to +90 is the normal axis. Pink one is the normal axis, green one is the left axis deviation, and yellow one is the extreme axis or northwest axis deviation, and the light yellow is the right axis deviation. Up to here, if it is any query, then please let me know, because other things will correlate subsequently. चंद्रिका, अरुण, कोई अभी इशू हो? चौरादीप, अंशिता, चलूं आगे? ठीक है.
Yes.
Now coming to the QT interval. For assessing the QT interval, the lead 2 is most commonly used. Rarely we have to use the lead B5. How do we assess the QT interval? From start of Q. This is the start of Q. We have to draw a line just at the level of PR segment. PR segment is from end of P wave to start of the Q wave. A horizontal line we have to draw like this. If the Q wave is very broad, then we have to draw a tangent line like this, where it is intersecting. This is the end of T wave. Sorry, this is the end of T wave. So we have to calculate from here, from start of Q to end of the T wave. The basic formula, as we all know, everybody is using the QT. We have, as we measured from here, oblique square root of RR interval. RR interval we have to use the previous one just before this. Okay, a normal QTC should be less than 0.44 second. First 6 months will have QTC interval 0.4 up to 0.49 second is normal. In newborn, we are seeing lots of ECG, newborn ECG, that is having prolonged QTC, because newborn is as it is a normal finding also in first 6 months, and newborn is generally is having hypothermia or hypocalcemia, hypomagnesemia, that will also have the prolonged QTC. So we have to assess the electrolytes, especially in newborn, and the QT interval. A rough idea we have to measure. Then we have to see whether this. You can see we have to measure from start of Q wave to end of T wave. The end of T wave should not exceed half of the RR interval. R and R, between these two, 1, 2, 2.5 large boxes are there between these two RR interval. The end of the T wave should fall by मतलब जो एंड ऑफ द टी वेव है वो इसके हाफ से पहले फॉल करनी चाहिए, लेकिन इसमें हम देख रहे हैं थोड़ा सा दूर जाके कहीं पड़ी, तो ये रफ आइडिया देता है कि इसका क्यूटीसी प्रोलॉन्ग है. ओके, तो रफली if you don't want to calculate, then we can assess by this also. Basics type, there are various types of long QTC, but generally in day-to-day practice we are seeing long QT1, 2 and 3. Long QT1 is generally triggered by the exercise, long QT2 by the emotional stress, and long QT3 by sleep or repose. Most common triggering factors are these three. And long QT1 is having broad and peak T wave. Long QT2 will have long ST segment. Long QT3 will have the long ST segment, and long QT2 will have the bifid T wave. Long QT1 is having broad and peak T wave. Long QT2 will have the M-shaped pattern of bifid T wave, and long QT3 will have the prolonged ST segment. In women, if the QTC is more than 0.46 second, it is abnormal. In men, up to 0.45 second is we think that it is normal. And in the absence of secondary causes, if it is more than 470 to 480 millisecond, it is almost proved long QT syndrome. And long QT, short QT is when the QTC is less than 390 millisecond or 0.39 second. Prolonged QTC causes, most common is the hypocalcemia, hypomagnesemia, myocarditis, and long QT syndromes like Romanov-Ward and Jervell-Lange-Nielsen syndrome. Short QTC generally we see in hypocalcemia and digitalis effects and congenital short QT syndrome. Few words about the ST segment. It should be isoelectric. It should have the normal baseline as of PR segment and elevation or depression of up to 1 mm in limb leads and 2 mm in chest leads. It is normal. Up to 1 mm in chest lead and 2 mm in chest, up to 1 mm in limb leads and 2 mm in chest leads, it is normal. And if the down sloping ST segment is followed by biphasic or inverted T wave, it is always pathological. Causes of pathological ST segment, most common in pediatric age group is seen in pericarditis and digitalis effect. Generally, we are not using digitalis frequently, so generally most common cause in pediatric age group is pericarditis. Few words about the T wave. The precordial T wave configuration changes over time. It should go, the T wave should go with the QRS. अगर QRS नीचे जा रहा है, तो T wave भी नीचे जाएगी. QRS is positive in positive deflection, the T wave should also go with the positive deflection. In the first week of life, T waves are upright throughout the V1 to V6. Please listen carefully. In the first week of life, the T wave is upright through the chest leads. But after the first week, the T wave inverted in V1 to V3. This is a normal phenomenon known as the juvenile T wave pattern. And it persists mostly up to 8 years. Sometimes we are seeing up to 12 years also. And persistence of upright T wave in V1 beyond first week, that means there is some problem is there in newborn. The maximum height of T wave is 6 mm in limb leads and 10 mm in precordial leads. A rough idea is if the T wave is exceeding 2/3 of the preceding QRS, it is tall, and if it is less than 1/8 of the preceding QRS, it is small. And for assessing the T wave, generally we use the V5 and V6. हम pediatric इस ग्रुप में क्या होता है कि chest lead लेना छोटे बच्चों में पॉसिबल नहीं होता, कई बारी चीजें मिस होती हैं. I am having a patient that is having WPW syndrome In limb lead, we can't see any abnormality, but in the chest lead, there is a pre-excitation clearly shown in the ECG. I will show you in the subsequent slide. So we have to check the chest lead also if it is possible. The causes of peak tall T wave is most common is the hyperkalemia in pediatric age group. Inverted T wave is generally not seen until unless there is conduction abnormalities. Flat or low T wave is generally seen in hypokalemia and digitalis effect. Now, few words about the hypokalemia. When the potassium is less than 2.5 millimole per liter, the prominent U wave you will see like this. This is the end of T wave followed by U wave. This is known as the prolonged QU interval. And the T wave either biphasic because of the U wave, or it will be the flat, and the ST segment will be depressed. As the potassium will fall, the PR interval will prolong, and the sinoatrial block may occur. So we have to be very careful when the potassium is less than 2 millimole per liter. This is a potassium of 1.7. As we can see, the ST segment is depressed. ST segment is depressed and T wave is inverted. And the prominent U wave is also there. You can see here is the deflection in the form of prominent U wave. The potassium, as the potassium will go down and the U wave will appear. Few words about the hyperkalemia. Tall wave, as we can see, as the potassium is more than 6, the wave is tall, and prolongation of QRS duration. You can see the difference between QRS of this and this. The QRS is prolonged, P wave can be disappear, wide Vizare QRS sine wave pattern may occur. Eventually, asystole will occur as the potassium will increase. So more than 6 is lethal. This is a potassium of 7. You can see here tall symmetrical T wave. You can see here it is almost equal to the QRS. Here you can see the QRS. The potassium will increase. Long PR segment will be there. It is the PR segment. It is long and wide Vizare QRS. It is not of normal QRS duration. And if the potassium will further increase, the sine wave pattern will occur, and eventually the patient may go into asystole. Two words about the digitalis effect and digitalis toxicity. What is the digitalis effect? Digitalis effect is when we are giving digoxin. The digoxin should show signs in the ECG. It is known as the effect. And digitalis toxicity, when there is excess of digitalis, that will cause some changes in the ECG. But both have different patterns. You can see here, this is the depression of ST segment with the inversion of T wave. This is known as the Salvatore-Dali sagging appearance, as we read in our UG days, PG days, with flattened or inverted or biphasic waves with short QT interval. You can see here, this is a QT interval is short. Generally, it should fall, wave should fall here, but it is having short QT interval. Digitalis toxicity will lead to the disturbance in impulse generation and conduction. With prolonged PR interval is the earliest sign. With frequent PVCs, sometimes can lead to the AV block and sinus bradycardia. I am not going into detail. Now coming few cases that is important from pediatric point of view. This is a neonate, came with the history of shortness of breath, intermittent bradycardia. With echo showed severe LV dysfunction, came on CPAP with bradycardia. LV function is only 25%. And ECG, this is ECG. Any comment on ECG by anyone? Sinus or not sinus? Anyone? कोई तो बोलो. Sinus. But you can see here clearly the end of T wave. This is the end of T wave. It's falling more than half of the RR intervals. Half of the RR intervals somewhere will be here, but end of the T wave is just beyond the half of the RR interval. This is a clear-cut ECG of long QTC. If we don't want to calculate, we can assess by seeing this only. This is a long QTC. The patient neonate was having low ionized calcium, Everything else was normal. Given treatment in the form of IV calcium and vitamin D and gradual improvement in the QTC. Now you can see the QTC is normal. Another 6-year-old came with the history of recurrent syncope since 2 years of age, mostly with some activity. Important line is here is mostly with some activity, never at rest or on prolonged standing. As prolonged standing will cause basovagal syncope, so it is ruled out. And there is no normal physical examination with normal blood pressure. Sinus or not sinus? सबसे पहले हमें ये देखना है साइनस है या नहीं है. बताओ अरुण.
सर साइनस है सर.
QRS is normal or abnormal?
सर एबनॉर्मल सर. स्मॉल QRS.
चल ठीक है, मान लिया थोड़ा बहुत, लेकिन मोटा मोटा नॉर्मल है. और ये देखो AVL में देखोगे तो QRS बिल्कुल नॉर्मल है. अगर एबनॉर्मल होगा तो सब जगह एबनॉर्मल होगा.
सर ये स्प्लिट QRS है सर 1-2 में.
QTC,
M.
you can see the QTC end of the T wave. This
Increase.
is another, as I told you,
Increase, sir.
mostly with some activity means the patient is having some form of long QTC, especially the type 1 long QTC syndrome is there. The red flag sign in syncope is when the chest pain, dyspnea, palpitation, or some form of structural heart disease like Epstein. Syncope that occurs during exercise with some activity like swimming, loud noise, or in the sleep is typical of long QT syndromes. If there are any family history of deafness, family history of sudden unexpected death, especially in the young age and or in the previous sibling, these are the red flag signs in case of syncope. So we have to be very careful. Another case, this is my personal experience. 16 days old newborn came on ventilator for cardiorespiratory failure for last 2 days. Patient was in tachycardia, increased capillary filling time with almost low blood pressure with poor urine output. X-ray shows cardiomegaly. Heart rate was 296 beats per minute. Regular tachycardia with poor LV function. अभी सौरदीप, अंशिता है? अंशिता से तो बात ही नहीं हो पा रही. अंशिता कम हो गए बच्चे.
सर नैरो QRS कॉम्प्लेक्स.
Narrow QRS. This is a typical ECG of supraventricular tachycardia. Okay, this is the ECG taken in NICU. There was transient adenosine effect, but there is recurrence of supraventricular tachycardia. We started with IV metoprolol and oral flecainide, but problem was there ki IV metoprolol was not responding and oral flecainide gives some response, but it further leads to increase in long QT interval. That's why we have to stop the flecainide. Later on, finally, after giving amidron, flecainide, and other medicines, the patient responded on IV metoprolol. Then on oral propranolol, patient was discharged. This was the ECG on follow-up. You can see here the test leads, 1 ABR, 2nd AVL, 3rd and ABF, all is normal. But you can see here in V4, in V1, slurring of QRS. You see carefully that circle, you can see the slurring of QRS is there. The patient is still in follow-up. The patient is around, I think, 2 to 3 years of age on propanol. This is a clear-cut case of left-sided pre-excitation. The patient is waiting for RF ablation. This is the follow-up ECG. Pre-adenosine ECG was there. Post-adenosine, if the patient is responding, the patient will have normal sinus rhythm. Another case, 1.5 month old came with the history of feeding difficulty, respiratory distress, and poor pulses. Patient was in hypotension and shock-like state. X-ray again showed cardiomegaly with poor LV function. I'm sorry for the poor ECG quality, but you have to see these arrows. 1 ABL V5 V6. What is that? Are these normal or abnormal? First of all, what is that arrow? Age is 1.5 with signs of heart failure with patient is in shock. This is a deep Q wave in left lateral leads. It always indicates the age of presentation is generally around 1 to 2 months of age in the form of heart failure, inconsolable crying. So we have to see the ECG. If the characteristic L kappa is there, then we will be able to find out such type of ECG. The treatment is, as soon as diagnosis is made, the treatment is surgery. Another case, 2 days old neonate with bradycardia with a heart rate of 58 beats per minute. On patient is in heart failure, distress, CPAP support, cardiomegaly, and with poor LV function. So many cardiomegaly and so many poor LV function spectrum is there. This is the ECG. I wrote the treatment. This is typical ECG of, you can see here, this is the P wave, P wave, P wave, P wave, P wave. P wave is coming at regular interval. There is no change in the arrival of P wave, but QRS is beating at its own rate. It is regular, and P wave is also regular, but there is no correlation of P and QRS. This is a typical ECG of congenital heart block. Treatment is pacemaker. When the patient is having less than 55 or less than 70 beats per minute with structural heart disease, and when it is less than 55 with no structural heart disease, the treatment is pacemaker. 10-year-old symptomatic, consulted for abnormal heart sound or murmur outside, came with a asymptomatic murmur with grade 2/6 ejection systolic murmur at left upper sternal body. Patient is asymptomatic. Any comment on the X-ray? What is that in X-ray? Anyone? Anyone? Anshita Dhani? Saradeep?
Sir, pulmonary plethora.
Pulmonary plethora is there. Pulmonary plethora is there. The right heart is enlarged, right atrium is enlarged, right ventricle is also dilated. This is a typical X-ray of large atrial septal defect. This is a zoomed image of ECG. Otherwise, you can see here. You have to see the second third. Second wave is here. Second lead is here. You can see the splintered QRS in the lead 3 and AVF. This is typical crochet sign, but not always seen in case of secondary type of atrial septal defect. And the axis is almost normal. But sometimes it leads to the right axis deviation depending on the how much is the right ventricle enlarged. Another case, 2-year-old with failure to thrive, cardiomegaly is there, pansystolic murmur at apex, but ejection systolic murmur at left upper sternal border. What is the axis in this patient? You have to see lead 1 and AVF. This is a case of ASD. Okay, I am telling you the diagnosis. This is a case of ASD, but what type of ASD you have to decide by seeing the axis. You have to find out lead 1 and AVF. And let me know what is the axis.
Right axis deviation.
Kaise?
Sir, one in
I
positive
am in
and
class, please wait. I am in class, please wait. Lead 1 is positive.
lead ABF is negative. So left axis deviation.
Yes, this patient is having left axis deviation. This is typically seen in ostium primum type of defect or AV canal type of defect. Understood? Ostium secundum will have right axis deviation. Ostium primum or AV canal will have left axis deviation. The pansystolic murmur is apex due to mitral regurgitation, and ejection systolic murmur at left second intercostal space is due to the increased flow through the pulmonary vein. Understood? Saradeep?
Yes, sir.
Okay. Another patient, 3 months old, came with the some murmur, poor weight gain, difficulty in feeding. The typical large VSD presentation is there. I am telling you the diagnosis. You have to tell me what is the finding in ECG. You have to see. Basically, this ECG is not so good. You can see here in lead 2 downward. You can see there is a prolonged T wave with upright T wave. This is LV volume overload with broad and equivocal QRS segment. Up is also there, down is also there. Equivocal. This is known as a Wetzel phenomena seen in case of large VSD. It is not of classical type. 6-month-old infant with loud ejection systolic murmur, more on the right side, right upper sternal border as compared to the left upper sternal border. You have to see the V5 and V6 and let me know. Previous ECG was having upright T wave, but in this patient, V5, V6 is having inverted T wave with peak R wave. This is seen in case of LV strain type of physiology, namely as aortic stenosis. An aortic stenosis, the LV will not be volume overload. LV will be hypertrophied and will be in strain. The strain will cause T wave inversion. Volume overload will cause T wave upright, but it will be prolonged. Okay, this is case of severe valvular AS. Treatment is ballooning. LV dilatation will have upright T wave, prolonged and upright T wave. Okay. The typical presentation of TOF. 2 months old, suddenly got cyanosis while defecating in morning during crying. Saturation sleeping is 80 to 84%. Other things are in favor of TOF. What is the classical finding in TOF? If it is there, Chandrika, V1 and V2, what is the difference?
Sir, T wave inversion in V1 and
It is normal
elevation.
in newborn. मतलब 2 months के बच्चे में नॉर्मल है, मैंने पहले बताया था कि पहले एक हफ्ते में अपराइट होती है, इसके बाद इन्वर्टेड हो जाती है. V1 में QRS, हाँ जी क्या?
QRS tall, so right ventricular hypertrophy.
Okay, and what is in V2? There is sudden transition from V1 to V2. V1 is having totally positive QRS, V2 is having sudden negative QRS. Understood? Getting my point or not?
Yes, sir.
So this is a typical ECG seen in case of TOF, but it is not always seen. But if you are seeing such type of ECG, that means patient is having large VSD, infundibular VSD with severe pulmonary stenosis. It can be TOF, it can be double outlet right ventricle, it can be single ventricle with pulmonary stenosis. Anything that is having TOF like VSD will have such type of presentation. 1 month old, deeply cyanosed, single S2. Axis is, what is the axis? Arun, axis?
Left axis.
Left axis. What can be the causes of left axis? Generally, newborn is having right axis?
Tricuspid ratio.
Yes. Kisna bola? Saradeep?
Yes.
Very good. Newborn is having right axis deviation normally. If newborn is having left axis deviation, means the ECG is abnormal. This is typically seen in right tricuspid atresia because the right ventricle is hypoplastic, only the left-sided ventricle is predominant, that this patient will have left axis deviation in the form of tricuspid atresia. As you can see the lowermost part of the ECG, you can see the typical sawtooth like P wave is there. This is atrial flutter. In the case 2 months old, 2 years old, asymptomatic, abnormal sound on right side of the heart. Comment on the X-ray, please.
Right heart enlargement, sir.
So dextrocardia.
Dextrocardia, yes.
Hiatus soletus.
Sinus soletus, dextrocardia is the ECG finding. Oh, X-ray finding. What is the meaning of sinus soletus in ECG? Saradip, tumhi batao.
So in X-ray, heart will be shifted.
ECG. I am talking to you. ECG. What is the meaning of sinus soletus in ECG?
Sir, AVR will be positive. AVR will be positive in dextrocardia.
What is normal P wave? Normally, what is the normal P wave in sinus soletus? Normally, P wave is upright in lead 1 and P wave is inverted in lead AVR. What we are seeing in this patient? Same?
Yes.
Positive in 1 and negative in AVR. This is an indication the patient is having sinus soletus. Understood?
Yes.
And the QRS duration, as we go from V1 to V6, if the lead are placed on the left side of the chest, normally placed chest leads are there, then the lead V1 is having the maximum deflection, followed by gradual deflection in lead V6 as we go away from the heart. This is a typical ECG of sinus soletus dextrocardia. Coming on the next, 3-year-old, again abnormal sound on the right side. What is that in X-ray? Is it same or some abnormality is there?
Hiatus invertus.
With dextrocardia. What we are seeing in this patient, lead 1 is having negative P wave, and lead AVR is having positive P wave. This is sinus inversus. अभी 5-10 मिनट लगे. Lead 1 is having negative, lead AVR is positive, and the deflections are getting decreased as we go from V1 to V6. This is sinus inversus dextrocardia. Got my the difference in sinus soletus dextrocardia and sinus inversus dextrocardia? Is it clear?
Yes, sir.
Yes, sir.
Now, what is this? This is a 10-year-old. 10-year-old came with the history of sudden chest pain after URI.
ST elevation.
With reciprocal ST depression. Oh, ST depression नहीं, sorry, वो जो क्या बोलते हैं उसको, PR segment depression. PR segment depression. Okay, this is typical ECG of pericarditis. You can see here, ST segment is elevated, PR segment is depressed. Okay. This is electrical alternance seen in. Electrical alternance means one QRS is normal, another QRS is small, normal, small, normal, small. Seen in
Congestive heart failure.
9. This is seen in cardiac tamponade. Okay. Cardiac tamponade will have one normal beat, one abnormal beat, one abnormal beat, one abnormal beat. To summarize, the ECG is useful in identifying situs and cardiac positions, as we saw in sinus soletus dextrocardia and vice versa. It is helpful in identifying various types of congenital heart diseases. It aids in assessing volume and pressure overloads. It identifies various types of electrolyte imbalances. Also helps in identifying the coronary abnormalities and tachycardia arrhythmias. Thank you very much. If there are any question, please let me know. बंदे 6 रह गए, स्वरादीप रह गया, चंद्रिका रह गई, अरुण रह गया. भाई पूछो जो भी पूछना हो. बाकी रिकॉर्डिंग आपको
डॉक्टर और पल्सेस अल्टरनेंस दोनों एक ही साथ आते हैं या मतलब
दोबारा बोलो, मैं सुन नहीं पाया.
तो जैसे पल्सेस अल्टरनेंस कंजेस्टिव हार्ट फेलियर में आते हैं और उसमें और इलेक्ट्रो अल्टर्स में डिफरेंस है.
नहीं, इलेक्ट्रिकल अल्टरनेंस इज इन ईसीजी फाइंडिंग, पल्सेस अल्टरनेंस इज फिजिकल फाइंडिंग. Pulses alternance is also seen in case of tamponade.
सर ये साइटस इन्वर्सस वाली ईसीजी दोबारा बताएंगे सर?
एक मिनट रुको, शेयर करो। नॉर्मली क्या होता है, P wave is upright in lead 1 and negative in AVR. You can see in this ECG the P wave is upright in lead 1 and negative in AVR. This is typically seen in case of situs solidus. कोई भी आप ECG उठा के देखना नॉर्मल वार्ड का, जो साइटस सॉलिडस होगा ऐसा ही दिखाई देगा। अब हम आते हैं साइटस इन्वर्सस पे। इसमें क्या है, ये स्टमक बबल इज ऑन द राइट साइड, नॉर्मली लेफ्ट साइड में होती है, बट हियर इज इन द right side. It is situs inversus. You can see here in lead 1 is negative in negative P wave is in lead 1 and positive in AVR.
Yes sir. Yes
So
sir.
this is the difference.
Yes sir.
Now you got?
Yes sir. Yes sir.
और पूछो। If anything is there, then let me know. I am always. डॉक्टर बिपुल?
नहीं सर, और पूछने का कुछ नहीं है, बहुत सारा इनपुट मिल गया।
आपकी रिकॉर्डिंग आप शेयर कर दें।
दो पार्ट्स में होता तो और मजा आता।
हाँ, 2 पार्ट्स में होना चाहिए, बहुत लेंथी है सर ये, बहुत
काफी कुछ स्क्वीज कर दिया आपने 1 घंटे के।
ठीक है सर, बाय बाय।
ओके, थैंक यू फॉर ब्रीफिंग। थैंक यू जी।
बाय बाय।
Thank you, sir.
ओके बाय।